peptic ulcer disease. There are two types. We have gastric or duodenal ulcers. So let's review a little bit about our GI tract. So what's protecting our GI tract from our own gastric juices? Okay, the mucosal lining, right? So we have from our mouth down to our rectum, we have goblet cells, which are mucus producing cells. These cells, of course, are microscopic. They need, therefore, microscopic circulation as well, meaning tiny, even microscopic capillaries to supply them. So as long as this balance is there, there's enough blood flow to these goblet cells, and then we have enough mucus being produced, no problem. Our stomach lining, our intestinal lining are safe from our own gastric acids. So how do we get peptic ulcers, therefore? There are two main causes. They are chronic NSAID use, and the other is H. pylori infections. NSAID use, of course, these are people, mostly are elderly or those with chronic inflammatory conditions such as lupus, rheumatoid arthritis, osteoarthritis, those that have inflammatory type of pain for which there is no other relief except NSAIDs. Okay? So if these people are taking NSAIDs more than the average person and do not take precautionary medications along with it, by precautionary medications, we mean either misoprostol or H2 receptor blockers or proton pump inhibitors to protect the acid producing cells. Okay, so that can cause peptic ulcers. The other is a Helicobacter pylori, which is a bacterial infection. We pick this up pretty commonly, probably from violating the 5-minute rule. Okay, so eating something after 5 minutes. Okay, so 5 minutes is okay. Just watch the food there for 5 minutes, pick it up later. As long as you don't meet the, 5 minutes. So if it's 5 minutes or less, it's still okay to eat, right? Yeah. You want to drop that food for, is it 5 seconds or 5 minutes? I heard it was 5 minutes.
5 seconds.
5 seconds.
Oh, I didn't know that. Back home, it's 5 minutes. Anyway, so what can you say about an organism that can live in the environment of your stomach? Imagine you being inside somebody's stomach. What is it like in there? So a person eats breakfast in the morning, then so you'll be drowning there with food, right? And then acid is being produced, and then there's milk or whatever they're drinking. Then there's beer or juices or bubble tea. Is it a nice, cozy environment? No, very acidic, probably the worst possible place to be, right? So what can you say if an H. pylori organism can live and thrive in that environment? What can you say about the H. pylori organism? A badass organism, yeah? Okay, so since it's badass, it can withstand environments like that, is it easy or hard to kill? Pretty hard to kill, okay? So we'll talk about management of that later. As already mentioned, the use of NSAIDs, not just occasional use. You take NSAIDs for a toothache or a headache, for instance. That is not what we're talking about here. This is chronic daily NSAID use. People who have, pop these pills 6 to 8 times a day. Okay, that kind of chronic NSAID use. Other factors that can contribute to peptic ulcer development are the following: smoking and alcohol, that also increases acid production and can therefore promote the formation of peptic ulcers. There are other conditions like this one, for instance, ZES. is a rare condition. Causes you to have increased production of gastrin, which in turn, of course, increases the stomach acids. Okay. So I already described to you how you get it. Skip through the pathophysiology. We already discussed that. Now, stress ulcers are actually not peptic ulcers. Okay, this is it's been thought to have been caused by, because it says stress ulcers, right? But these are there are different types of stress ulcers. We have Curling's ulcers, which are common in people who have critical illnesses, long-term acute or chronic illnesses, like or let's say critical patients who are in the ICU. Okay, because sick people have high stress hormones, right? Therefore, we'll have increased stomach acid production, and then that will form Curling's ulcers, or we also call them Cushing's ulcers. They are different ulcers. They are not peptic ulcers. Just stress. Okay, so stress ulcers are not peptic ulcers. Okay, so they're not the same. They're not lumped the same, because obviously, is the treatment the same? No, because the causes are not different. So I already mentioned Curling's and Cushing's ulcers, frequently again seen in critical patients. Manifestations depends on whether your peptic ulcer is gastric or duodenal. Main difference between the two is the occurrence of the pain. When does the pain occur? The accompanying manifestations are similar, meaning besides the pain, the patient will also have dyspepsia, nausea, vomiting, or even sometimes accompanied by bleeding as well. So this is the description of the pain. The main difference is really the onset of the pain. Thank you for reading. It's Lavi.
Manifestations that differentiate gastric ulcers from duodenal ulcers. However, classically, the pain associated with gastric ulcers most commonly occurs immediately after eating, whereas the pain associated with duodenal ulcers most commonly occurs 2 to 3 hours after meals.
Okay, thank you. And here's also a difference of 50 to 80% of patients with duodenal ulcers are waken up by the pain at night. Now, the nature of the pain is because of the physiology. Okay, so when we eat, how long does the food stay in our stomach? Does it go straight into your duodenum? No. So that's why we feel full after eating, because the food stays in the stomach for how long? 1 to 1.5 hours. So does it make sense that if you have an ulcer in the stomach, and again, once you put food in your mouth, digestion begins, correct? By digestion, we mean stomach acids are released automatically. So once you swallow that food, stomach acid production begins already in the stomach. So does it make sense that the pain, if you have a gastric ulcer, begins immediately after eating? Okay, so that would explain it. Whereas, why would the duodenal ulcer pain occur later? Okay, because the food again sits in the stomach, and therefore the acid and the food does not enter the duodenum until about 2 hours after eating. Okay, so that's the simple explanation. As already mentioned, there are accompanying manifestations, dyspepsia, or there could be also gas, burping. Yeah. No, dyspepsia is like indigestion. The most serious complication of peptic ulcer is perforation and also bleeding. But however, once there's perforation, then that will snowball into, because either intestinal or gastric contents now spill into the sterile peritoneum. So once you have perforation, that can also lead to peritonitis, then eventually sepsis, septic shock, and death. As already mentioned, there is some accompanying bleeding here, depending on how deep is the ulcer already. If the ulcers aren't that deep, then the less likelihood of bleeding. So the deeper it is, of course, that will expose the blood vessels now, large blood vessels of the stomach or the duodenum, exposing them to acid and then causing bleeding. This bleeding can range from minor bleeding to hemorrhage. Okay, so depends really on the size of the ulcer and how many we're talking about and how deep they are. How do we diagnose? Well, besides the symptoms, the patient must have an endoscopy. So EGD stands for what? Okay, so EGD is an endoscopic procedure where we insert a scope into your mouth, down your esophagus, into your stomach, right into your small intestine. Visually, we have to see the ulcer in order to make a diagnosis. And with every ulcer, with every endoscopy, a biopsy will be taken to test for H. pylori. Because again, you either have H. pylori infection or NSAIDs. Those are the two most common causes of peptic ulcers. If it's the case of H. pylori, of course, we have to treat it, right? Because it's an infection, it's an active infection. So we'll treat it with antibiotics. If it's NSAIDs used, then we'll talk about options. Okay? If the patient cannot absolutely avoid NSAIDs, meaning they need NSAIDs for a chronic condition, then we'll have to add some medications to prevent new ulcers from forming and allow the existing ulcers to heal. So here's management. So let's start with H. pylori first. Treatment is antibiotics. Now, the combination will be 2 antibiotics and 1 PPI or H2 receptor blocker. Why 2 antibiotics? Again, it's a badass organism. So we need to make sure we kill it with 2 types of antibiotics. So it's 10 to 14 days long. Again, 2 antibiotics. Now this is the combination. Okay, we cannot interchange it. It's either metronidazole, which is Flagyl, or amoxicillin and clarithromycin. Okay, that's one combination plus a PPI. Okay, so we call that triple therapy. Okay, so we also have another combination. We can also have quadruple. So 2 antibiotics still, metronidazole and tetracycline, plus a PPI and Pepto-Bismol. H2 receptor blockers can be also used instead of a PPI. Yes, yeah. Yeah, or H2 receptor blocker. Or like mentioned here, you can also add Pepto-Bismol. So here are your drug regimens. Okay, so any of these combinations, and this is the period of time you'll be taking them. I won't read them for you. Let's talk about NSAIDs. If the cause of the NSAID of the peptic ulcer is NSAIDs, chronic NSAID use, as evidenced by, of course, we ruled out H. pylori. We did endoscopy, we took a biopsy, it was negative. No H. pylori was found. So we point to the patient's history of taking the NSAIDs. If this is the case, then the patient will be prescribed misoprostol. What is misoprostol? This is a prostaglandin analog. Reason is NSAIDs are prostaglandin inhibitors, correct? If you read the drug book, the action of NSAIDs is it inhibits prostaglandin synthesis. So therefore, since NSAIDs prohibit or prevent prostaglandin synthesis, then you will give a prostaglandin analog, okay? Because there are many types of prostaglandin. Now, the prostaglandin that NSAIDs are inhibiting are those that transmit are neurotransmitters for pain. Okay, that's there's many types of prostaglandin. The problem is they inhibit all of them. So therefore, if you give misoprostol, it will prevent some of the prostaglandins from being inhibited. Okay, so they meaning they promote the prostaglandins because prostaglandins are vasodilators, which is essential for microcirculation. So to supply blood to the mucus producing cells, they rely on prostaglandin. Okay, so therefore we give misoprostol. Caution, of course, is since misoprostol is a abortion drug. So if the patient is childbearing age, so we need to check for pregnancy first and then make sure the patient stays non-pregnant while on misoprostol. And this is the action of misoprostol, how it causes abortion. It softens the cervix. All right. There is no NSAID that will not cause peptic ulcers. However, there are NSAIDs that are less likely to cause peptic ulcers. That's another option. Okay, so instead of Aleve or what are other brands out there? No, no, the ibuprofen. Yeah, Motrin. Okay, so aside from those, there is something called celecoxib. Okay, that's still an NSAID, but that's compared to other NSAIDs, that's the least likely to cause peptic ulcers. Celecoxib. That's all I know.
Just celecoxib.
Okay, as already mentioned, misoprostol should not be taken by pregnant women or those who are planning to get pregnant. Naproxen is just as bad as ibuprofen. As already mentioned earlier, smoking and alcohol does contribute, so smoking cessation is part of the therapy. Dietary modifications, if you read the whole paragraph, there is really no diet to help heal peptic ulcers. The rule here is, yes, you can avoid alcohol, especially caffeinated beverages, but nutrition wise, there's really no food or group of foods that will help heal an ulcer. So the general rule is if the patient eats something that aggravates the condition, meaning they eat something or drink something that causes symptoms, then what would you do? Avoid those foods. Okay, so it's really specific to the person. Okay, what foods trigger or aggravate the symptoms? Then simple, avoid them. Again, if the patient is fine with the spicy food, eat it. If it causes symptoms, of course, stop. Okay. However, in hospitalized patients who have active aggravated symptoms, for instance, of course, the patient will be NPO. We'll keep them alive with IV fluids, and then slowly introduce soft foods. Usually, the diet given in the hospital is bland, no taste whatsoever. Dry toast, something like that. No flavor. But that's only because the patient has acute symptoms and are in the hospital. But at home, really, there's the doctor won't prescribe anything. They'll just say, okay, just eat whatever you can tolerate and avoid those that cause symptoms. Surgical management, we won't discuss. This is no different from the surgical management for Crohn's and ulcerative colitis, as already you did that med search 1, I think. Okay, so we'll skip table 40-4. For the other medications, they are actually listed under gastritis. So let's go to the gastritis section. And then we'll come back here for complications. So let's go to gastritis under medical management. Right. So same, we already mentioned about H2 receptor blockers and or proton pump inhibitors. There should be a table here. Okay, right here. Table 40-2. So this is for both gastritis and peptic ulcer disease. So we've seen already the antibiotics and the pepto and also the H2 receptor blockers, and we have PPIs. Be familiar with the name, okay? On the exam, I won't use PPIs or H2 receptor blockers. I'll give you the drug names. Okay? So you have to be familiar with the names. And here's misoprostol. And there's one new drug here, which was not mentioned under PPIs. We have sucralfate. Brand name is Carafate. So what is this? This is a coating agent. So we call this a mucosal barrier fortifier. When you ingest this, it will form a coating on the surface of the ulcer. So it's like a foamy coat. In order for this to work, this has to be taken 1 hour before meals and 2 hours before and after other medications. You can also give this at bedtime because we do have stomach acid production while we sleep, correct? So to make sure you don't have the symptoms, you give one at bedtime. So this would be 4 times a day, correct? Yeah. Because it's 1 hour before meals, before each meal, and then one at bedtime. Okay?
So before and after meals, right?
Before meals. 1 hour before meals.
1 hour before meals, one at bedtime.
One at bedtime. Because will it make sense that if you take it 1 hour before meal, so this will coat the ulcer. So once you eat, acid is produced. Will the acid now touch the ulcer? No, because you have sucralfate already ingested and coated the ulcers. Okay, let's go back to complications of peptic ulcers now. Okay, we discussed the first three. Let's look at complications. So most common complications are hemorrhage. Since we already finished shock, particularly hypovolemic shock, so management here is the same. So what's your first intervention? Patient is actively bleeding. What will be given first? Blood or fluids? Okay, fluids. Unless you have blood in your pocket, then yeah, fluids first. So stabilize the patient's blood pressure. We give bolus amounts of fluid, and until blood product is available, then we'll give the blood transfusion. So expect some blood transfusion questions for exam 1, because now we have 2, right? One for shock, then another for hemorrhage under peptic ulcer disease. Now, if the patient, of course, is actively bleeding and the hemoglobin is unstable, meaning hemoglobin is below 7, which is when we transfuse, correct? And plus the patient's actively bleeding, is it a good idea to take them to endoscopy? No, they'll just bleed to death there. So therefore, a patient must be stabilized first, because eventually the bleeding will stop, correct? I mean, we have a clotting cascade, yeah? So once we have a wound, for instance, it will stop, right? There's no such thing as it will bleed indefinitely, yeah? Because we have the clotting cascade. So of course, we form a clot, it will stop the bleeding. To prevent rebleeding, however, because remember, once you have an exposed blood vessel, whether an artery or a vein, there's a clot momentarily stopping the bleeding. Once you wash it with more acid, what will happen to that clot? Yeah, so the blood vessel will bleed again. So therefore, what can be given during the active episode? So we mentioned fluids, blood. What else will be given? What will stop the acid?
Stop the acid.
PPIs or H2 receptor blockers must be given. So the rationale for the PPI or H2 receptor blockers is to prevent rebleeding. Okay, because it will bleed again. Okay, because once you have acid again, even though the clot is already there on the blood vessel, once you expose the blood vessel to more acid, it will bleed again. All right. So PPI, so expect this. This is for every GI bleed patient, okay? Whether it's caused by peptic ulcers or something else, right? Doesn't matter. GI bleed management is the same. It's always what's given first? Fluids, then expect blood to be given and PPIs. The PPIs here can either be twice daily IV pushes, but if it's active bleeding, doctors will order it a continuous infusion. But so if you give 40 milligrams of, let's say, pantoprazole twice a day, so if it's a continuous infusion, that's about 5 to 20 milligrams per hour, okay, infusion, continuous infusion. And then once the patient is stable, then we'll take them to endoscopy. Remember, it won't mention here about shock, okay? But can this patient go into shock? Okay, so shock already from chapter 12, so we won't repeat that. So shock was chapter 10 or 12? 10, yeah? I think so. So I won't repeat this hemorrhagic shock mentioned in this paragraph. We finished that already from module 1. Okay, another complication is perforation and penetration. So perforation is there's a hole in your stomach or in your duodenum. So how do we know there's a hole there now? What diagnostic test will show this? Not really an endoscopy. The endoscopy will show an ulcer, but these are microscopic holes.
Oh, they give you pills to swallow?
So what tests will show that there's a hole in your stomach, or what would come out of that hole? There's air in our GI tract, correct? Yep. Okay, so when you get a CAT scan, where will you see the air? Inside the bowels or outside? Because is air inside the stomach or the bowels normal? Inside? Yes. Where do you think your fart comes from? Okay. So yes, it's normal to see them inside, but is it normal to see them outside? We call that free air. Okay, so if there's free air anywhere in your abdominal cavity, where did that air come from?
From the hole.
From the hole. Okay, so meaning your stomach or your small intestine farted inside your peritoneum. Is that bad? Yes, because that's dirty air, correct? Remember, your GI tract is dirty, but the peritoneum is sterile. So therefore, if you have fecal material or even food particles in your peritoneum, can that cause peritonitis? Can that cause sepsis? Can that cause septic shock?
Yeah.
Can that cause death? Yes. So here are your manifestations. Now, of course, perforation automatically means there will be peritonitis, correct? So the manifestations here, do not be wondering, oh, aren't these signs and symptoms of peritonitis? Yes, that's exactly what's going to happen. Because once you have perforation, of course, expect peritonitis. Okay? So sudden severe abdominal pain, it will depend on where is the ulcer, because the pain will be localized around that area first, and then of course it will spread eventually when you have full-blown peritonitis. And here are the accompanying manifestations. So don't they resemble a heart attack?
Yes.
Similar, right? So you have to rule out, of course, when you come in with these symptoms, doctor will of course rule out, is this cardiac? So we'll put you on cardiac monitor, get an EKG, get cardiac troponins. Then once we rule that out, oh, no STT wave changes, no troponin, let's go GI, okay? So here is now extremely tender, rigid, that's now serious peritonitis, meaning the entire peritoneum is now involved. But the problem here, this will occur if the patient stays too long at home, meaning they babysit those symptoms, okay? So they just tough it out, "Oh, I'll be okay in the morning, okay? Just keep taking Rolaids or Tums, for instance, okay? And then when they come in, they're already very septic. Okay, remember, peritonitis leads to sepsis, and there you go. So can peptic ulcers kill? Yes, right? Serious. Another part of the treatment is, especially if the patient has severe pain, we will have to put in, and bleeding as well, we put in an NG tube. The purpose of the NG tube was because what do you expect to happen when you have perforation, when you have peritonitis? Will there be peristalsis? Will there be bowel movements, peristalsis? No, it will stop. Okay, so peristalsis will stop. Of course, that will make the symptoms worse. Patient will have nausea, vomiting nonstop, bloating, okay, abdominal distension. Plus, of course, do you want them to vomit constantly? No, patient will have aspiration, especially now if they're bleeding. Of course, that will mean lethargy, okay, altered mental status, decreased level of consciousness. And what will happen if the patient's mental status is like that and they vomit? Can they protect their airway? No. Aspiration pneumonia, sepsis, septic shock, death. All right. So NG tube will be inserted. The purpose of the NG tube, of course, is to what? Well, decompress the stomach, okay, so that the patient stops vomiting, and then we, of course, we evacuate all the gas, blood, stomach contents, okay? There's also gastric outlet obstruction. This will again cause the following symptoms: nausea, vomiting, constipation, epigastric fullness, anorexia, and eventually weight loss. And to treat this, of course, we just put in NG tube, okay, until the obstruction is relieved. Obstruction is relieved by surgical procedure, of course, endoscopy. If endoscopy can't do it, then we'll have to do open abdominal surgery. That's about it. Any questions on peptic ulcers?